let's begin a little bit more on meds. So turn in your briefs to page 17, and top of the page is Bydureon. And Bydureon, it's not used as much as, but the point is how it all developed. Bydureon is administered for diabetics like insulin, but it isn't insulin, once a week. Go to page, it's still in the briefs, but go to page 21, and you see the second from the bottom, Victoza. Victoza, administered sub-Q once daily, but can be used in place of Byetta for glycemic control. Keep your finger at 21, keep your finger at 17, and at 17, right under Bydureon, you see Byetta. Byetta was probably the first glycemic sub-Q other than insulin that we used, administer sub-Q, but it's a GI hormone used to slow GI absorption of food, thus decreasing carbohydrate absorption or blood sugar level. And it was kind of the first one that came out. It doesn't say it there, but it was before each meal, or twice a day, twice a day, and it was before meals. So that was the first one. I keep these three. They've got some more now out there. Byetta was the first. Victoza was wonderful because then it was once a day. And that was a real, and it didn't have to be right there at eating time. And then they went to Bydureon, which is the once a week. And they're all this GI hormone. And you may have heard the story. The scientists discovered that the Gila monster in Arizona looks like an iguana. Didn't have to eat for 6 months or 6 weeks or quite a long time. They could go without eating. And so they wondered why, and in dissecting, they realized they had an enzyme that could slow absorption. And so Byetta is a GI hormone that slows up absorption. And if we slow up digestion and absorption, then the amount of insulin our pancreas puts out can keep up. The whole problem is with diabetes 2 is our pancreas isn't working quite as good as it should, or it may have just quit here in old age, or something stopped it. It's not diabetic 1, it's not type 1, it's type 2 that usually comes on a little later, and I'm going to talk more about it in the next session when we do diabetes. But the point is that lost my train of thought. That if you put out less sugar in the bloodstream, the pancreas, in its slow putting out of insulin, not like optimum, can keep up with it. And that's why these work, because of absorption. So it isn't insulin, it's a GI hormone, and it was first discovered in the Gila monster that looks kind of like a iguana. We're going to talk more on diabetes. I think it's next week. I'll talk diabetes. Then Caldolor, and that is IV ibuprofen, which is wonderful, but it's not, I think I told you, that one and the IV Tylenol. Let me tell you where that one is. While we're talking, we might as well mention them together. if I can find
Page 20.
20.
Offerma.
Thank you.
Yeah.
Page 20. See, I don't, Ofirmev, OFIRMEV, page 20, is the acetaminophen, is the IV acetaminophen, Tylenol. And I bring them up, you can tell I'm not that familiar with it, because I had to bumble around, but they're great. We just don't use them a lot, and I've asked why we don't, and I think it's the price. The word I hear is it's the price. Now they could pass it on to you, but I think the insurance company would question, why is this IV acetaminophen so costly when you could give a PO? Well, it's just not the same when it's in the vein and been processed. So if you give it, and it comes in a little bag, and you IV piggyback it, and quite effective, quicker, and of course than the PO. Carafate, and the thing to remember, and we may have already mentioned, I think we did, where I tell you it's kind of like a covering over the sore. Didn't I mention that? So Carafate, it will cause a food ball, aka Bezor is the word, and the med will cover the ulcer for 6 weeks, but allows absorption in the stomach, and if the sore is not gone in 6 weeks, it's a more serious problem, because you ought to heal that sore. With a covering protecting it, you ought to heal it in 6 weeks. Catapress is an alpha anergic blood pressure, aka clonidine. Cipro IV won't mix with anything. It's used for MRSA, methicillin-resistant Staphylococcus aureus. Avoid drinking or eating milk products at the same time. Wait about 4 hours so they don't join each other in the stomach. And there's your colony stimulating factor. We've already mentioned those 3 drugs last time. Neupogen, white blood cell booster. Numega, colony booster for platelets. And then Epigen, booster for red. And then corticosteroid inhaler, and there's some of them listed. And you know, anytime you do a steroid, you run the risk of increasing blood sugars. And I mean, that's, your body can usually handle it, but I'm just saying. Corticosteroid nasal, there they are. Should take topical decongestant 5 to 15 minutes before that, and it'll be more effective. Cortisporum opthal or optic drops. Now, I have, this is all still page 17. They don't use wicks so much, and I don't know why. Have y'all ever used the wick in the ear? Well, it's never been much. I've seen it used a little bit, but not a lot. But the physician, I think it's clever, and I don't know why it isn't used more, unless research showed it wasn't that effective. You know, somebody has otitis media, they put the drops in, and it's the antibiotic. Well, it's a little cotton wick, and when you put it in there, it's kind of like the material of a tampon. When you put it in there and then put the antibiotic solution on it, it swells, and so the whole ear gets that distribution constantly. See, I think that's clever, but it's not done much. Well, you and I, we put the drops in, they hang their head up, and it all comes out. So I don't know why it's never, unless research didn't, I don't know. I've never heard it explained. But if you come across the wick, you just put it on there, it swells and stays, and you can remove it how often you want to put another wick in and put your ointment on. But you can go the next treatment, just leave it in and put the ointment, the antibacterial antibiotic drops on. After an ear infection has run its course, peroxide's good to wash out the exudate. And I think I've already talked to you about the xylocaine aralgin drops that are nothing but xylocaine, but it's oil. And for doctors to order that and the antibiotic ointments and not explain to people that this is for pain, but it's oily. So if you put it in for pain and then the antibiotic, it's going to have to go through a lot of oil to get to. And I don't think they explain that, so I want you to do that. Coumadin is best given at the same time each day, and just keeping a good schedule of that. It just does more effectiveness. And cyclosporin, and it's given for rejection in transplant patients, and cytomegalovirus, the CMV. And it's just something good you hope pharmacy would send the word to give glass or metal, not plastic. And if it's a capsule, you open the capsule, mix it with that. I think PDR says pineapple juice is actually the best, but you don't see that around too much. Deadens the taste. It can be given IV, but it's made differently, and the shelf life is only 6 hours for a bag of 12, or 12 hours for a bottle. Cymbalta is an antidepressant, but it's also used for diabetic neuropathies. Now, what I want you to realize is antidepressants, it's not that they especially have a magical medication in them, but antidepressants, one of the biggest things they do is increase circulation. And if they increase circulation, the oxygen and nutrients go to the brain, and that's what helps your depression, is shooting a big supply of oxygen and nutrients to the brain. And yeah, it probably has a property in it that might boost something, some kind of cholinergic something, acetylcholine or something. But the biggest thing it does is circulation. So if you had stinging feet because of circulation, your feet sting, they'll give an antidepressant for the same reason, to make that flow of blood go down there. Why do you ever pain or hurt? And a lot of times it's because of that tissue isn't getting the right amount of oxygen, or that's why in a heart attack or infarct, it hurts so bad because oxygen and nutrients aren't getting to the tissue, and that's mostly why pain happens. Swelling will cause pain because the flow can't get to it. It's such a common sense thing. So just realize antidepressants, just because people are on them doesn't mean they're depressed. It may mean they have tingling, their circulation's bad. And so that's why Cymbalta mentions can be for neuropathies when you have stinging or inefficient circulation. Dakin's solution, it smells like Clorox. It's very dilute, only 5% Clorox, but you smell it. And it's for wet to dry dressings. A lot of times the two products is saline, wet to dry, and Dakin's. And I'll talk more next session. I think it's next that we do our demonstration. But when you're stuffing a wet to dry, that Dakin's that have been absorbed, your clings or your pads have been soaked, and you're pushing it into your wound, then it'll dry. You've covered it, but the body heat will dry it, and that's when you pull it out and it's dry, and it may stick and bleed. That's bringing circulation. And I think I've told you I think I've already mentioned that, did I? On wet to dry, and that you don't want to wet it before you bring it out, just so it doesn't pull and bleed. That's exactly what we want, is the pulling and bleeding. That's why we want it dry, so we can pull it and it makes some bleed and circulation goes there. DDAVP on page 18. That is antidiuretic hormone, and desmopressin you can call it, but most people call it DDAVP. I'm going to talk more about that when we get to endocrine. Neurohypophysis is your pituitary gland. And I think I told you some of the children at my camp are on DDAVP so they don't wet their bed and embarrass themselves at camp. So the family physician puts them on DDAVP. Demerol can be used for chills. I just put it in. Of course, you know it's analgesic. Desferol extracts D, and you see it. DE takes away. When you have dehydration, it's taking away water. Well, this takes away iron, ferrous or ferrol. Extracts serum iron. D to take out ferrol iron, used in patients getting too many transfusions. Because iron doesn't break down. It eventually, we keep using it for our red cells. Boy, you can get too much. Dilantin, and that's, I think we've already discussed, didn't we? Don't do dilantin. Don't mix dextrose and dilantin. And they will, I think you can visually see them like concrete, become milky. But just because something doesn't change visual doesn't mean decomposition doesn't happen. And y'all, this nurse, and I, on our floor, and I don't know whether any of you all were with me, we have a syringe that's hard to IV push. It comes, an analgesic comes and you IV push. She says we were having trouble getting the air out, and it's a new type syringe. She said it is just too hard. I just squirted in a medicine cup and then aspirate it back up. Medicine cup isn't sterile. And I told her, I said, were you with me, Melanie? I said, well, it isn't sterile. Yeah, I know it. But I didn't bother. Anyway, it just happened to, why did I think of that? Because of, why I thought of it. Just mixing, I guess, is what made me think of it. Dilaudid is hydromorphone. And then dopamine. And the reason I bring up dopamine, 3 mics is micrograms, and it increases renal perfusion. Anything 3, and anytime you're ever in a unit or you hear them say, how much dopamine are they on? And they say 2 mics. Well, what they don't say is 2 mics per kilogram per minute. That's what they're really saying. And so you need to know their weight per kilogram. And then per minute, then you multiply it 60 for the hour. And then you have to look at your bag to see how many micrograms make a milligram. More than 3 mics increases heart rate. And I just bring that up because sometimes we just need renal perfusion. So that would be 3 or under mics. More than 3 mics, we probably are needing it for heart rate. Doxadan and Colase, warm in microwave if given through a feeding tube. And you'd have to be really careful. Start with 5 seconds because things can happen. That's doxycycline, which is of course an antibiotic. It's kind of blurred out on mine, but photosensitive. It is vibramycin. V is in victory. fibromycin. And if you take it PO, they need to sit up for 30 minutes and with a full glass of water. It is, as I said, photosensitive. If it's IV, it's in a brown bag to protect it from light. There's your Eliquis, that's anticoagulant. And for the cardiac issues, Coumadin was used for years and years and years so that cardiac issues, if you don't beat good, then it gets sluggish. Blood in the heart gets sluggish. Blood in the lungs gets sluggish if that contraction is not really good. And in that sluggishness, it's easy for blood to attach to sludge. And so we get a clot. And so Coumadin was the absolute best. And I bet it's 10 years ago I went to a seminar at Vanderbilt when we were still nothing but Coumadin. May have been 12 years, but it hadn't been that long. And I remember raising my hand and said, are they ever going to come out with something? Because it was only 12 years ago, and it was the only thing being used. And then pretty soon, they started coming out. Eliquis, Plavix, and others. Now, as I think said in here, Coumadin does have an antidote, vitamin D. The others don't. And I have a friend that lives 5 hours from San Jose, Costa Rica, and she really had issues being on an anticoagulant, and she's 5 hours from a hospital. Scares her to not be able to clot. And especially if you're on, and she's on Eliquis with no antidote. And so do you go to Coumadin that has a wonderful antidote, but you got to come in 5 hours for blood test every, 6 weeks is it, or something like that? They have to do it. Epigen, we've already talked about. Procreate stimulates the MARA to make red cells. Then iron, and remember, vitamin C increases absorption of iron. We said it last week. Iron needs vitamin C doesn't need iron. Just to kind of give it a boot. Gamma globulin is an antibody, and we're going to talk the immunology another session. Gantrazin is a sulfur medication. It's anti-infective. Any antibiotic is different than anti-infective, and I think we've already maybe said that. Antibiotic, I've already said, is anti-life. Antibio is anti-life. But anti-infective makes the milieu, makes the surrounding area hostile to living. And so that's the way it dies, is that the area around doesn't support life. So it dies. It isn't like it kills it. So sulfur does that. Heparin, the prophylactic, is 5,000 units in a milliliter. Now we're using Lovenox. There's several. We're using various ones that are the same thing. The heparin drip comes in a bag. It's 25,000 units in 250 milliliters. And it may, according to your facility, but not pretty much that's standard. And the doctor will always order in units an hour. Well, the pumps are milliliters an hour. So you have to, you can tell if 25,000 units are in 250 milliliters, it would be 100 units is in 1 milliliter. So if the physician ordered 1,800 units an hour, it would be 18 milliliters. Heplock is a solution used if the IV, to keep the IV patent. It's very dilute, 100 units in a milliliter. And heparin drip's 100 units in a milliliter, but this Heplock comes in just a 1 milliliter vial. Imuran is the most powerful immunosuppressant if you had organ rejection issues. Interferon is iron, and it's an injection of iron, and it's Z-track, and so that iron does not seep out. It's very caustic to the skin and vein, and makes it look like a tattoo if it does come out, because and it'll stay for life. It's an oily injection and can be given Z-track to prevent the oily med from retracting back skin surface. Now, this is an independent action. The doctor does not have to order that it be Z-track. I want you to know, any oily medication you give IM, you can choose to do Z-track. And if you recall, Z-track is nothing but pushing tissue over. Give the medicine, bring it out. You don't even have no reason to aspirate. And we're really not aspirating nowadays. And if it's iron, it's black, so you wouldn't know if you were in the blood vessel. But push tissue, push muscle over. Give it, keep your push, give it, and just as the needle comes out, Z it back, and it seals it. I had a neighbor that wanted me to give her estrogen shots, and I did. The first time I did it, the estrogen all came back out because it's oily. I don't know whether you've ever given estrogen, but it's oily, and it just started coming back because it was a hole, and it just coming out the hole. So the next time I did it, I didn't tell her, oh, it's all out. I didn't do that. Just the next time she needed it, I did it Z-track, and then it's sealed. So do it anytime you think, yeah, well, I can tell you, if you're going to do anything oily, you ought to Z-track it. Now, insulins, we're going to talk about that when we do IVs. And then, so we'll go on and skip that part on page 19. And let's go to the IV drip meds. Nothing much to say about that. Let's don't worry about that. The KCO runs, we've been over that, haven't we? Okay, good. Keflax is a PO antibiotic. Lasix's been around a long time. Furosemide. And then Levaquin, it's given PO, but you should turn a feeding pump off 1 hour before giving the med and turn the pump back on an hour after giving it. It can be taken with food or without food, but apparently with formulas. And there's certain formulas it really doesn't work with, so they just say, why don't you just not let it mix with any formula, not try to remember which formulas for a feeding pump. Lidoderm is just topical anesthetic, and a lot of times for neuralgia. Lithium is kind of interesting. It's for bipolar or mania, and And then lorazepam, which is Ativan, can be used to help drug withdrawal, but not DTs. Lorazepam or Ativan. It's a good drug. Now let's save our last page. Well, we've got a couple of more pages. Let's save them. 3 more. So we're going to stop with page 20 at the top, microdata. All right. And moving along, let's talk about, let's do hematology. And if you've seen the YouTube on hematology, it won't be everything I've said, but the basics of what I'm saying, so you've got that. But we've done little snippets about blood every session, our other 4 sessions, but just as a review, and I do know some of it I have repeated, I have said too. But we've got the blood, and we especially talked when we were given blood last week. So you've got your blood and you've got your three cells: red for nutrition and oxygen, white for fighting, and then platelets for clotting. And that takes up 45% of our blood. 55% is plasma. We discussed that. Plasma involves water, fibrinogen for clotting, albumin for osmosis. I just think that's the most beautiful thing, that it allows seepage through membrane. And if you don't have enough albumin, we don't permeate membranes. Our nutrition doesn't go across, our waste doesn't come back. We've got to have a good membrane diffuse system, and that's albumin. And I just think that's so wonderful and not appreciated enough, albumin. And then gamma globulin are all our antibodies, which we'll talk more on antibodies when we do immunology. Is that everything? Water, fibrinogen, gamma globulin, and albumin. The life of the cells, I think we talked, but I'll mention it again. Red, 120 days. White, anywhere from minutes to hours to days to weeks to months to years. That's how long white cells. You have a germ in your bloodstream or your body, and those white cells multiply so fast, so their life may have been real quick. So it could be any amount of time on white. Platelets, 10 days, unless transfused, and I think we mentioned that, only 24 hours if you get a transfusion of platelets. And we know from last week, you only get a transfusion of platelets if it's scary. You're down at 10,000 or something like that, and we want 100,000. Your chance of bleeding your brain out or someplace is big. The hematocrit, I told you I like 40. You can memorize women and you can memorize men, but I just love the number 40. That's great. And you know hemoglobin, that I say is your carrying. It's not, I don't want to call it the liquid of the cells, but it's the definition of hemoglobin is oxygen carrying capacity. So it's what's carrying my red cell, and it's a third the size. So if I have a 40, my hemoglobin automatically is a little over 13. 13.3, I guess. And I mentioned last week, hematocrit's the same thing as packed cell volume. It's an old term, but some people still use it. And I just think it's just fascinating that our cells are in this big rush of blood, but when they narrow down to the capillary, they go single file. And I just think that's wonderful. Think of a tunnel that a train is going through. That train goes through, and some material is dropped off and some's picked up into the carts or the cells. Some cells give oxygen and nutrient and take off waste, CO2, and go on, and then backtrack and come on back up and get another load. Empty out the CO2 in the lungs and the urine, and re-up with oxygen and nutrients by going out into our GI tract or the blood. It's such a beautiful, beautiful mechanism. And we mostly are making we talked about it, we're mostly making those cells in the marrow. When fetuses are growing, they mostly make their cells in their liver. You and I really back off by the time of birth, we're pretty much not, the fetus is not making that much in the liver. You and I are making especially our long bones. Of course, we know the kidney has a real relationship with red blood cell. And it's not, they say it produces, red blood cells. You know, if you've got kidney problems, you probably have red blood cell issues. But it's only because it produces erythropoietin, which is a hormone that stimulates the marrow. So the kidneys produce this chemical that stimulates red blood. So it's true, if you've got kidney problems, you've got red blood cell problems, but it's not because the kidneys are making them. It produces erythropoietin, which stimulates the marrow. And I think you all know 4,000 to 5,000 white cells is what I want. 40 of hematocrit, and 100,000 to 450,000 for platelets, and that's on your card that you have. Red blood cells, erythrocytes, which is hematocrit, really, but they're 4,000 to 5,000, I think. I never memorized it because I just look at hematocrit, but red blood cells, if you want to look at them, about 4,000 to 5,000, but if you look at hematocrit, that's enough. CBC, complete blood count, it's kind of a misnomer because it's just hemoglobin, hematocrit, and white blood cells. And that's not complete if you ask me, because where are platelets? And platelets are not included. The physician has to write CBC and platelets. I think that's odd, but that's the way it is. Unless your facility has made the blanket statement, CBC in this hospital is platelets too. So you just have to be sure what's your facility. Now, I wanted to talk about the white cells. And I've already told you 5,000 to 10,000. I've told you they live minutes, hours, days. But we've got 5 kinds. And are they right there?
Yeah.
Page 9, 11 in the agenda. And they may be, I think they're also, I'm looking in page 11 in the agenda. Page 11. Yeah, you can see the 5 white blood cells. But also, I've got another place for you. Maybe in briefs. Let's look at that. Y'all look with me. It may be under terms. Let me see data. Anybody see the white blood cells of administration? Well, I don't want to take a lot of time, but I'll find it. I know it's in here somewhere. IVs. Lymphocytes, neutrophils. Maybe under labs. Thought it had, well, I can't find it, so we won't. I'll look at break. So they're white, they're 5 whites, And you see them there on page 11, eosinophils. That, if they're elevated, now when I say 5 to 10,000, that's the whole gamut. But if eosinophils are high, it's usually an allergy. We've got an allergic issue. And that's about all I'll say. I don't even tell you to memorize the norms, because that's easy, so don't even get into that. Basophils, and you hardly have any. And so it usually, if you have any, you've got a blood dyscrasia. You've got a blood problem, like leukemia. There's a problem with a disease of your blood if you've got basophils. And then lymphocytes, if lymphocytes are increased, you've got probably a viral issue. Viral. And then monocytes, literature usually says we don't know exactly what that white cell does. They know that they help everything else. They assist in cleaning up white cells, and so they're kind of a helper to virus cleanup and bacterial cleanup. But the one I wanted to really put some time on is neutrophils. Do they list it as neutrophils?
Mm-hmm. Yes.
And neutrophils, they don't, on page 11, break that down, but I want you to. Neutrophils indicates bacterial. Your infection, if you came back with, I was in an emergency room with a physician, and the WBCs came back at 18,000. He said, well, we have an infection, bacterial. And so we knew it was bacterial because the neutrophils were high. But one time I was where the WBCs came back, they had not done a differential. This is the differential, the 5. So the physician has to ask for a differential. And the emergency room I was in with this physician, he ordered WBC, a complete blood count. Well, it came up, the white were real high. But he's not any smarter because he doesn't know, is it viral or bacterial? So now, he realizes he should have said with a differential. And then they would have run the complete blood count and said 18,000, and here is the breakdown. And then if he saw that the neutrophils were high, the normal, he would know it's bacterial. If the lymphocytes were high, he'd know it's viral and know what to do with it or not. And so here's the way neutrophils works. They have other names. It depends on your hospital. They're called segs or segmented neutrophils. They're called neutrophils, as we're listed here. They're called polysegs. And they're called polymorphs, polymorphonuclear spills. So listen to me when I say the adult fighting bacterial WBCs could be called segs, polysegs, neutrophils, polymorphs. This depends on your hospital. Now, that's adult. I told you adult. Of all the white cells, there's only one, and that's neutrophils, that breaks down by age. I told you basophils, lymphocytes, eosinophils, they are born adults. But neutrophils, they show us the growing up of them, and that's important to us to know how far or where is our bacterial infection. So, the younger ones are in neutrophil. The babies of all that have just been born to fight, to grow up and fight. They can't fight yet, but they're going to grow up real quick because I have some germs that are bacterial, and that word got out, and they are producing fast, and they're going to be grown in hours. But the babies are called juveniles or juves. And then the teenagers, I call them, are called stabs or bands. I think bands are on there. I thought, yeah. They put some bands on there. So they're kind of the teenage. And then the adult, you already know their names. So if a physician ordered a CBC and differential, then you need to look at those younger ones. And so just common sense, say to yourself, well, the neutrophils look normal. And so, I mean, the WBCs said 12,000. So we've got an infection, but is it bacterial or is it viral? And so you look at your differential. We know WBCs are high. Well, the differential shows that juves are higher than normal, but neutrophils, well, I said they're high. Juves are high too. A hospital only does one of the younger ones. This hospital on page 11 uses bands. That's fine. You don't need them both. You just need to know, are they growing up? Is it a high number that are young? Because if the young number is out of range in numbers, it means they're growing up to be adults, and it must be they're getting ready to fight. So, let me say it again. If young ones are high, but neutrophils are normal, then that infection just started and sent word. You start making them as fast as you can. And it, as I said, it could be bands or juves or stabs and juves. Stabs are the same as bands. Now look, if stabs are high and neutrophils are high, we are in the middle of a raging infection, because they're still saying, keep making them, making them, making them. I've got an army, but it's not going to be enough. I need more. I need more. And it's just a common sense thing. Now let's say that polymorphs are high, but bands are normal. Then the infection is resolving itself. The word has gotten out. I think it's under control. You can go back to normal production. So by looking at the old ones, the adult, and the younger ones, it tells you how far the infection has started and how aggressively it needs to be treated. So if you're in the throes of it, you go in and see the doctor and you're coughing, and the doctor sees the WBCs are 18,000 and does a differential, and neutrophils are sky high, stabs are sky high, that doctor needs to aggressively fight with antibiotics. If you said, I've had it 2 weeks, this cough, and the neutrophils are high, but the stabs are normal, then you're resolving it yourself. You're getting over it yourself. But I've never seen a physician not give them antibiotics, because they feel like in 2 weeks you wore yourself down and you are so susceptible to other bacteria. And so they'll give them an antibiotic, even though their body was doing a great job, and ask them to please fluids and rest so the body can still take over. I think the differential is fascinating. Of course, if your WBCs are 12,000 and neutrophils are fine, but eosinophils are high, then we've got some allergy going on. Or they're high, but lymphocytes are high, we've got a virus. And technically, you do not need an antibiotic. Now, you know the public loves antibiotics, and they want them. And so, a lot of times the doctor does it, and if you question them, they just say what I just said. Well, they've been sick, and their body's resistance is down. It's going to be, and that's true. It's going to be real easy to catch something that's bacterial. So, prophylactically, they give. But a virus, as we know, the antibiotic isn't going to help that at all. Just terms, and you know most of them, dyscrasia is a blood disease. Anemia is only red cells. Just keep in mind, anemia is red cells. People throw that word around like white or down. No, anemia is only red. Remember, penia, the end of a word, penia, is down, and ptosis on the end is high. So leuco is white. Leukocytosis is high white cells. Leukopenia, low white cells. And then I think you know stem cells are immature blood cells that when someone has cancer and they have destroyed a lot of their cells, their bone marrow has been damaged to try to quit making bad cells, then they may be given a stem cell transplant. Now these cells can come into the body and make what the body needs, the code, and not be full of cancer, we hope. Emia, of course, is blood. Polycythemia is a lot of cells, red. Poly, a lot of them. Cy cells that are red. Corpuscle is red cells. And I think you know sepsis is infection or blood poisoning, systemic bacteria. Now, some problems, let me go a little bit more, with problems with the cells, blood problems. Well, we know the red is anemias, and there's several anemias. So if someone has a problem with anemias, it could be diet, or it could be marrow is not working good. The most common anemia is iron deficiency. It's really the only one that the diet can help. Iron-rich foods, you know, we already know dried fruits are good. Egg yolks, meat, dried beans, all are iron. And then we know vitamin C can help that iron get in there. And we know red and green bell peppers, citrus. But you remember, it doesn't stay longer than 24. Most of the others, and I don't see any reason, maybe on the tape, the YouTube, and that's fine, you can listen. But remembering all the different anemias, and one is the enzyme for red cells is weak, or the covering in the red cell is weak, and it breaks quicker than 120 days. There are all kinds. I only want to mention one or two, the iron deficiency. And then there's folic acid deficiency, and you know folic acid is kind of it's kind of a B vitamin, and it's in milk and eggs and cabbage and cauliflower, Brussels sprouts, folic acid. The other one that I do think is noteworthy is pernicious anemia. It's not that it's so prevalent, or vitamin B12 deficiency. I just think it's an interesting anemia, because so we have the most common iron-rich diet, but pernicious diet isn't going to help. It is B12 is our problem. Well, can I take B12? You can. It's going right in your commode. It's not going to absorb. The body has that intrinsic factor in the GI system. It's called the intrinsic factor that helps with the absorption of B12. Not helps, it absorbs B12 for our body. So if we don't have the intrinsic factor, then we can't absorb B12. You can take it till the cows come home, all you want to, but it's not going to, it goes in the commode. You've got to have the intrinsic factor. So you go to the doctor because you're tired or you're short of breath, and a lot of people go because of the shortness of breath, because the red cells carry oxygen, and if you're down in your red cells, you can't breathe as good. So you go in, I just don't feel good, I'm tired, and the doctor said, well, yeah, you're anemic, I guess you are, and puts you on a diet of good, rich iron and vitamin C. I hope they know vitamin C. So often they forget to tell people that. When you come back, see, we know red cells takes about 4 months. So in about 3, the doctor wants to see you again. You're no better. So something is not right. Have you really been eating diet? Yes, religiously. Then we need another test. And the test that, because the doctor may be wondering then if you have a deficiency. And the first thought is pernicious anemia. And so here's what they do. It's called the Schilling's test, SCHILLLGS, Schilling's, I think that's right. Yeah. And I'm going to try to do it from memory because it's common sense. They give you a shot of B12. Now just follow me first. They give you a whopping shot of B12. Now that's going to absorb, yeah. It goes straight into the tissue, into the bloodstream, and you had so much that it's probably going to go into your urine. And when we started the Schillings at, we'll say 1 o'clock, Schillings started, they had you urinate, and you already know you throw away the urine from that. And if it started at 1 o'clock, you throw away the urine and put on the jug, empty jug, the time. Now, for 24 hours, you're collecting urine. And tomorrow at 1 o'clock, they urinate and it goes in the tub. Now, you ought to have at least even or excess, but at least even. When they did that injection, they also gave you some capsules of B12. And so if you have the intrinsic factor, and that's not your problem, you've got B12 here, B12 here, you in your urine have an enormous excess of B12. You follow? I got it here, I got it here. Guess what? You don't have pernicious anemia because your intrinsic factor absorbed that. If you just this, it would have probably been about even, maybe a little bit more, but it's sure not going to be gigantic. But if you've got the intrinsic factor, it's absorbing B12 here, and it's going to be huge. So then we know you don't have pernicious. Just makes sense, doesn't it, if you kind of think it out. So that's the Schilling's test. Your problem is something else. You may have, there's other kinds of anemias, the kind that your cell membrane is so weak it pops, and it doesn't live 120 days. So there are other kinds, and I don't see any point in you learning all of them unless you had it or knew nursing somebody with it, and you could Google that kind of anemia. Now, let me see what else I want to say on anemia. Oh, and the other one I really want to bring up is sickle cell anemia. And so, and of course, it's an adaptation. They say the red cells took on a mutation to fight malaria. And so it has this mutation. We don't have malaria, so it doesn't need it, but that tendency must be in the family or some way or other, the tendency to mutate into a crest. You know, our red cells are this around, but sickle cell makes it like a half moon. And if you visualize my train going through the tunnel, and one of the boxcars is not like round or not like it should be, it's a sickle, it catches on the side of the tunnel and stops. And the pain, you remember I told you that the oxygen giving and the bringing of the waste, but if you're not giving oxygen, you've got pain. Well, I gave all I had, but it stopped. I can't get through. And so I've already told you one of the biggest treatments is hydration. That pump is on 200, 250 to try to keep your blood moving fast. Push it through the tunnel. And the craziest thing is sickle cell usually happens with stress. You've got the mutation hereditary that happens, but you know, they go around free of their symptoms. But what triggers it? Well, one of the biggest things is stress will trigger it. Stress will trigger lots of things. We've had several on my floor that come in every time they have a crisis, and one was a medical student. She, I think, has died now, but then she lived long with it. She had a time getting through medical school, and I don't think she ever did. But exam week, you knew when it was exam week because she was here, and because that had put her in crisis. You know, crazy thing. So I've told you one of the treatments, you can just about common sense the treatments for sickle cell, and they are the high hydration, analgesic, of course, and oxygen. High oxygen, because the red cells that do get through, I want to be puffed as big with oxygen as possible. Now, yeah, I'm seeing that may be what I want to say on just anemias. Just a minute, let me make sure. You know, some anemias happen I told you, the shell around, the membrane around the red cell just may not be as strong, and it doesn't last 120 days. Some of them, medications will rupture them or just weaken them. So it's all kinds of things that could weaken that membrane around the red cells and become anemic. Now, we're not going to go into it right this minute. Let's break a minute and then start. We need to talk about problems with white cells and problems with platelets. So break. And one other thing I wanted to add on the anemias before we go further. A lot of times, nothing will help our anemias but transfusions. And we've already talked about with transfusions, iron doesn't dissipate. So we're just building up iron, building up. Well, we can't have veins just loaded with iron. So that's where your drug we mentioned, Disferol, will get rid of some of that iron for us so that our bloodstream isn't so loaded with iron. But with some of these anemias, and especially sickle cell, you hurt so bad because your red cells aren't getting, and you hurt and you take so much pain medicine that you become constipated. And so, needless to say, we need to work on that problem, is constipation. And I think it is in, let's just give it a try, in your briefs, go to medication, and I think we've already mentioned, but I'm just bringing it up again, page maybe 21 in the agenda, and I'm looking for, yes, and I was right, second from the top, Relistor, on page 21 of the briefs. Relistor is used for narcotic-induced constipation. And I don't know whether, have I already talked to y'all? Is that highlighted? We hadn't talked about it. It is a miracle. We hadn't used it in a while, but that doesn't mean they're not using it. It's just the days I'm here, we hadn't needed to. It is an absolute marvel. And it's usually given, it's not given to your ho-hum, run-of-the-mill constipation. It's usually from narcotic-induced, like these patients that are having to have so much analgesic. You put them on that, now here's what pharmacy tells, and we've done it. You put them on a bedside commode. He says, pharmacist said, get them on the commode. Give it sub-Q even. It's not even IV or IM, sub-Q, and within about the time you're through, it hits and they defecate.
Oh my goodness.
It's pretty miraculous. If they don't in 5 minutes, you repeat it. And I think they can repeat it up to a third time, and then they decide. But I've never seen it not work after the second time. It has sometimes not worked for us the first time. Give it a second and it will. So it's quite a drug. And then milk and molasses enema is great. Milk and molasses. And it's a 1-to-1. So I don't care how much you put in an enema bucket. Do you not have it?
No, I've had
Okay.
it, yes.
I don't know how much, it doesn't matter how much you put into your enema bucket of milk and molasses, just make sure it's 1-to-1. If you want to do a half a cup of milk and a half a cup of molasses, that's fine. And it's given just like an enema. And it is really good for narcotic induced constipation. Of course, O2 and IV fluids just to keep things moving. Now, I think that's what I want to say, so I want to go to white blood cell problems, and that would be your leukemias. Leuka is white, emia, and we want 5 to 10,000, and so when do we get real concerned? And I'm going to tell you, over 30,000 is when you think, ugh, this is getting too high for virus or bacteria. And you and I want high white to fight. We just don't want them that high. Because my example of that is if you had an electric mixer with dough in the bowl, and you're mixing cookie dough or cake dough, and you lift your mixer just a little bit, you know, it flies everywhere. Well, that's what those white cells are. They're not good cells. They're like splatters. And they're 100,000, and I want 5 to 10. I've got 100, but they're pathetic. They're strips. They're just not good, healthy cells. So that's why it's white anemia, white in the blood, and it's too many, and they're not effective. Now, you have the classic anemias, and it's called cancer of the blood, and you have, and we're not going to distinguish them, ALL, acute lymphocytic leukemia, AML, acute myelocytic, you don't need to know them, they're on that YouTube though, CLL, chronic lymphocytic leukemia, and chronic myeloid, CML, chronic myelocytic. The difference in them a lot of times are when it hits you. And you don't need to distinguish them. Acute is acute and chronic is chronic. Now that's good to know. You live a little longer with the chronic than the acute, unless it's arrested. The acute, why do they even go to the doctor? Usually leukemics go to the doctor, once again, why do we mostly go? When you are a little air hungry, or with them bruising. Well, now bruising has to do with clotting. So this is leukemia, this is white. White has to do with fight and flight, not bruising. But think about it. If my marrow is making all those awful white cells, so many of them, it's crowded out. The marrow isn't even able to make enough red or enough platelets. So it's so crowded with white that are terrible. I don't have enough platelets and I don't have enough red. So my red and platelets are down. My WBCs, lymphocytes, are high. Leukocytes are high. I've crowded out. So my red, I don't have enough and I'm not breathing good. And my platelets, I don't have enough and it's breaking. I'm bleeding out in tissue because my platelets are low. So yeah, it's not a disease of red and it's not a disease of platelets. It's a disease of white, but it's a crowding out that makes that problem. So somebody goes to the doctor just because they don't feel good, they're not breathing good, they're bruising all over. And of course, the physician then does a CBC with platelets because these bruises make me wonder. And it comes back low in everything but white. And the white is way up there, so that's not good. And so then they just hospitalize and we start trying to kill the bone marrow. For whatever reason, the bone marrow just went crazy and started making white that weren't any good. Now, it's willing to make the red and the platelets, but it just can't. It's so busy making white that are no good. And so the job of the medical community is to try to reprogram that marrow and get the bone marrow back on track. And by doing that, it almost destroys our white or marrow. And when they get down to hardly any WBCs with chemo, then they try to maybe a transplant of stem cells given to try get it up. And there's good results with leukemia right now. And just to bear watching, and that's all I'm going to say do is bear watching. A lot of times a child that has leukemia and goes into remission, and that is just simply all of a sudden the marrow decides, okay, I'll do right. And you go in remission and you're doing great. And that's a beautiful thing, and it's a miracle. And sometimes, but not always, adolescents, pre-adolescents, they get it again. And nobody quite knows why. And it's not everybody. But I never rest easy till they pass pubescence. When a childhood leukemic passes pubescence, that's a good thing. And they don't know whether the hormonal shift throws it or what, but it has been known that juvenile leukemics sometimes end up brain tumor, actually. A lot of them get brain tumor rather than repeat leukemia. They get a brain tumor. It's just an FYI. Not that I don't want you to be happy, and somebody in your church is in remission, please don't tell them now, I'm happy for you, but when they become pre-adolescent, watch. So you can keep it to yourself, the scary part of that. We have lymphomas, which is the lymph nodes are the problem. Tumors in the lymphatic system. And you know, our lymphatic system is a whole nother system of circulation of lymphatic tissue, lymph tissue, not our blood tissue, blood cells. And lymphomas are tumors in the lymphatic system. The worst part is they obstruct and are painful, and they'll cut off nerves and vessels. And the most famous is the Hodgkin's, Hodgkin's and non-Hodgkin's lymphomas. And I don't think it matters to you except if you hear the term. Hodgkin's is, you know, tumors in the lymphatic system, but if they biopsy them in certain kind of cell called Reed, R-E-E-D -Sternberg, S-T-E-R-N, Berg, B-E-R-G. If they find Reed-Sternberg cells, they know it's Hodgkin's. If they don't, they call it non-Hodgkin's. It's the more common of the lymphomas. Painful because of occlusions. And the biggest treatment is just debulking, try to cut down those, get them out or get them smaller. I then want to bring up multiple myeloma, because you do hear that one, and that's tumors in the bone marrow. Now that's not a good thing. And they'll even cause the bone to split. With that one, if somebody's deep pain and they get their urine 24 hours, now I tell you this because it's famous, there's a diagnostic test for multiple myeloma, and it's the 24-hour urine for Bence, B-E-N-C-E Jones, Bence Jones cells. It's protein in the urine. And it looks a certain way that they know it's Bence Jones. So anytime you saw the word Bence Jones, you know they're looking for multiple myeloma tumors in the blood, in the bone marrow. I do want to share this. If you see the initials CRAB, CRAB. It's in connection with multiple myeloma. C is calcium, and R is renal problems, insufficiency. A is anemia, and B is bone lesions or bone tumors. And they say if they pass CRAB, they have multiple myeloma. High calcium, renal insufficiency, anemia, and bone lesions. Whew, there's a lot that can go wrong with our body, and you're so fortunate when it doesn't. Now, so that's the hope of leukemics and lymphomas, and I think Jacqueline Kennedy had non-Hodgkin's, and it just begins to cut off vital functioning, and they can cut and debulk all those tumors they want to in the lymphatic system, but then does that block the lymphatic system, and then that holds up passage of flow in the lymphatic system. So now let's go to platelet problems. And the run of the mill, there's no real common platelet problem. Chemo wipes out platelets, of course, but I don't think there's any platelet disease that's real common, but I am going to tell you some that pop up. Of course, hemophilia we know of, and it's just, you and I have 13 clotting factors, praise the Lord. If you don't have at least 2, you're going to be a hemophiliac. You've got to have 13. If you lack 2, then you are a hemophiliac. Of course, the most famous is the Tsar of Russia, Nicholas's son, who was 8 years old, and I know more about his progress reading Nicholas and Alexander, and because it told about taking care of him, and he was 8 years old, and it really gives you the life of a hemophiliac. And he, because just brushing up against something then causes the hemorrhaging, and they can't clot, and so it gets bigger and bigger, and with that pain again because of the swelling against nerves, and then pain because the flow can't put oxygen into tissue. Now there is a and then if it's in the joints, it's horrendous if it's in the joints. And it's gender, sex linked. It's carried by women, but it happens in men or males. At my camp, one of the counselors, he's very attractive and very defined, and he is a hemophiliac. And he came in with terrible stomach pain, and I mean double over stomach pain. And his father is a physician, and we didn't know what to do with him, and it was like a Sunday, and I mean he's in college, and the father came to camp to take him home and decided it was a kidney stone. And it ended up, which made sense to us, but later he sent back word it wasn't. But before his daddy got there, I sat on the side of the bed and visited with him. How do you live being a hemophiliac and you're at a boys' camp? How much activity can you really do? And he was active enough. I mean, you didn't see him. He never played a combative type sport. But I asked him, and let me say, he doesn't have a lot of joy, and he's good looking, but he doesn't that face is not, it's a sad face. It's not a happy face. And he indicated to me the stress. And I would be, wouldn't you, that somebody hit you, or a car accident, or whatever. But that's hemophilia. Von Willebrand, Von, V-O-N, Willebrand, Willa, W-I-L-L-E, brand. It's just missing one factor. So it's not nearly what hemophilia is. And they don't bleed in their joints. And it can be passed to females as well as males. You're diagnosed because you have frequent nosebleeds and easy bleeding. Women have strong menstrual cycles if they have von Willebrand. The interesting thing about it is they go to the doctor for the same reason anybody goes to the doctor that has platelet problems. They're bruising, and they can't think of any reason that they would. Von Willebrand is it's an interesting, I've seen it in a couple of children at camp. I've seen it, but also college age, and that's an interesting thing to me, that it happens then. And let me see. No, forget it. Forget that. That's what I was looking for. I was trying to distinguish. Von Willebrand is just what it says. It's just not as severe as hemophilia. The one I want to slip into is ITP. ITP. Idiopathic. You don't have to write it down necessarily, but idiopathic means strange as it may seem. Idiopathic thrombocytopenia. Penia low, thromboplatelets, the platelets are low. Purpura. ITP. Idiopathic thrombocytopenia, purpura. Now that's the one that I've seen a couple of times at camp, and it happens so often with college students. And what it is they're bruising. And here's the deal. Take your briefs and turn to, and I'm going to say page 21 in the briefs. Go to steroids, and you see the first thing they do is coat platelets so the spleen won't kill them. You see that? Coats platelets so the spleen won't kill them. Well, this is ITP. One, I think it's the weirdest, but you know, so many illnesses are weird. One day, and it is, you don't see it in children. I've seen it in 2 children, I think, but mostly I've seen it in college age. They wake up one morning and they do notice that they're bruised, and they go to the, and with that, that just bothers them. So they go to the doctor, and they're not particularly dyspneic. It's not that they can't breathe, it's mostly this bruising. So they go to the doctor, or student health, that's where I've heard of it so much. And of course, when the doctor sees the bruising, anytime a caregiver sees bruising, it's not your concern. So they run CBC and platelets, and they see platelets are way down, but red and white are fine. but platelets are down. Well, that's not leukemia. So praise the Lord. We know it wasn't the same. And they weren't short of breath. Well, no, because they're red, we're fine. And so here's what happens. When they see that, they wonder if it's ITP. And here's what happens. You wake up one morning and the body decides that my platelets don't belong to me. And so I need to kill them. And our body has that wonderful capacity to make antibodies. And so it decides that this platelet isn't belonging to me, so it makes an antibody that grabs it and is going to kill it. But for whatever reason, it just becomes a parasite, and that antibody just rides with it. And the platelet will still work. The problem is when it passes the spleen, you know what the spleen loves to cull out, and it culls anything that doesn't look right. Well, that doesn't look right with a big old antibody sitting on top. So the spleen kills it. So the spleen's the problem. If it didn't have to bypass the spleen, you say, well, let's just remove the spleen. Well, we'd rather not, because the spleen does some good. It gets rid of some bad cells that we would prefer not to have. So the first thing they try to do, they can give a steroid. And I call it greasing it up. If they give a high enough steroid, it'll grease and pass through the spleen and tricks the spleen. And that's where that first property coats platelets so that they pass through the spleen. The doctor tries that first, and I need to ask somebody if they're still doing that first. And I think they are, because that's your least invasive. Now, you can't stay on steroids too long. You get the moon face, the buffalo neck, and the spindly extremities, and the thick midriff. So after 6 weeks, and you're no better, then the physician needs to try something else. They have several things. They can put you in the hospital and give you antibodies that try to kill try to destroy the antibody platelet. The thing is, as you know, when things go through the spleen and the spleen kills it, the spleen starts getting huge. And so, you know, if that person is bruised, goes to the doctor, they'll lay down. Now, you and I may not be able to feel a spleen, but if it's enlarged, you'll feel a knot. And so they try to kill the antibody with an antibody. They do that. If that doesn't look like it's working, they will do a splenectomy. And the craziest thing, the craziness of starting is just as crazy the ending. One day you wake up and it's like, oh, you were mine all the time. I'll quit making an antibody to kill you. Is that not the wildest thing that was? But that's ITP, idiopathic. It's crazy is the word. Crazy thrombocytopenia, purpura. Treatment, steroids, then an antibody. And let me mention, IV antibody, or any antibodies, capital I, lowercase g, and then lowercase other letters. Anytime you see a capital I, a lowercase g, and then letters after their lowercase, that's an antibody solution. Our body has antibodies like that, and one type goes and fights respiratory. One type of antibody goes and fights blood problems. The beauty of antibodies that our body has made and uses if they need to. So, anytime you're in reading and see capital I, lowercase g, and any small lowercase a, it's a certain kind of antibody. Now, one other, and it's more rare than ITP. When I say rare, I've seen several. So it is rare, but not that rare. TTP, which is thrombotic, like thrombus, a clot, thrombotic thrombocytopenia. So those platelets are clustering now and making a clot. Now they didn't make a clot in ITP, but they do in TTP. And you can guess what we're going to do about that, anticoagulant. There was a patient here from Memphis with TTP, and I hadn't heard of TTP at the time, and I talked to them, and I said, it's not the same as ITP, because I was reading. They said, no, but in Memphis, they treated us for ITP. They thought I had ITP, and then they discovered it was thrombotic. The platelets, for whatever reason, it's not an antibody particularly, they just start clustering together, and that isn't good. It occludes, so an anticoagulant you need. You can have polycythemia, too many red cells, and a lot of those people need to give transfusion. What's too many? When your hematocrit is getting up there to 60, then we don't like thick blood either. And so clots are inclined. Now the last one that I wanted to do on platelets is DIC, disseminated intravascular coagulation, DIC. And mostly people just say DIC, they don't go disseminated intravascular coagulation. And it's triggered. Nobody knows. You and I have never maybe had it, but doesn't mean we never will. It's as freak as ITP, that one day you wake up and the body thinks it doesn't belong with you and wants to kill it. This is just as crazy. One day, you either have a bacteria in you, and the body, I'll tell you what the body does, goes crazy. Not bacteria, I didn't mean to say that. That one day it just changes its pattern, and I'll explain that to you. With platelets, I made this up myself, but I like it. Comparison. I'm not really been to an Amish farm or Mennonite. I've been Mennonite, but not Amish. But I've seen movies and I've read books. And the farm is out there, everybody's working hard. And if there's any emergency or problem, they ring a bell and everybody drops what they're doing. That's what they show in the movies, and run to help where the bells ring. So, when they get there, now they're all on top of each other, stepping on everybody. It's a mob. It's kind of like a cardiac arrest in a hospital. All the team arrives and everybody's on top of each other, and it can be just ridiculous. Well, my comparison is an Amish farm, when there's an emergency and the bell is rung and every male able-bodied drops their shovels, their plows, and all run to it. They get to that thing and it's just a mess. And then everybody back here, the wolves and coyotes can get everybody left at home, the women and children. Well, to me, that's what DIC is. One day, the body doesn't like it's something that triggers, usually it's gram-negative bacteria, or it's and sepsis, or with a gram-negative, or it's huge loss of blood. Something triggers the body out of homeostasis, and you and I have been out of homeostasis, so nobody knows when it's going to happen, but it triggers that everything that's anything rushes to the area of embarrassment. If it's a gram-negative rod, they run to that. Everything, cells, chemicals, and when they get there, you guessed it, they're all over each other and they clot. Back here, there's no protection on the farm, and so they just bleed out. Coyotes come and they bleed out because everything that made up what was protection went to there. That's DIC. I've got bleed, I've got clotting, all going on at the same time. And so which do you treat first? Well, if you give an anticoagulant, you've got the choice. Do I give an anticoagulant or do I give blood? And the first treatment is an anticoagulant. Now, they've got blood. If they're bleeding out, we've got to get blood in them too, of course. So you can't really say first and second because you're going to be doing both. But it seems odd if you're bleeding out to give heparin, but you're trying to keep more clotting from happening. As I said, loss of blood will start it, trigger it. Not everybody, or the gram-negative. And those are your two reasons it might happen. And labor and delivery, a delivery pours blood out a lot of times. And they may go into DIC, but they don't treat them with heparin. They just transfuse them. Now, they don't want them to have, they're careful the rest of their life. It's like a bracelet, never to have heparin, because something's wrong. They couldn't get them stopped. And it wasn't their platelets, it was this freak DIC going on. I had two incidents that I just think the body is so peculiar. I worked in the emergency room at Dallas, Texas at Parkland, and I've told you we're in areas of the emergency room, doctor, nurse, and tech. You went in every morning and found out where you worked. So it really made me love to be a generalist, to know a little bit about everything. And so it was a Sunday morning, and a 19-year-old came in. Aftermath of a Saturday night's usually calm. If you've worked in a hospital on Sunday morning, it's usually quiet because everybody's calm. So I was in minor medicine, which is flu, colds, doctor, me, and a tech. And it was emptied out. Nobody was in there. So we're kind of cleaning after the rough Saturday night. The doctor's got his feet on the desk, reading the paper and drinking a cup of coffee. In comes a 19-year-old fellow, and it's flu-like. He's just chills, fever. So I put him in the cubicle, and he had a temp of 99, I think. He just felt bad. He looked bad. I mean, he looked sick and chilling. And so I did his vital signs and got some kind of history. Went in to give the paper to the doctor, and he said, "What is it?" And I told him what I told you. And he finished his coffee and his newspaper and went in, talked to him a few minutes, enough, came out, and he said, "I tell you, he's on his thumb." Actually, he was from Nashville, he said. And he was on buses, finger, what do they call it? Hitchhiking. Mm-hmm. And he said, "Give him a couple of Tylenol." and a blanket and pillow, and let's let him just rest, because he is on the go. He spent last night at the Greyhound bus station. So that's what I did. And so I'm kind of straightening around the unit, and the tech is too. And the head nurse came, if you've read Manchester's book, Death of a President, because it was Parkland, but it was after him, Manchester calls her the Great White Starched Dragon, he calls her, because she was starched and bossy, and she came through, and you were pretty awesome around her. She came through and said, "What's going on? Anything?" I said, "No, just that." And just as we turned for me to say, "I've just got this one that's got the flu," you could see through the curtain at him. And I said, "We've got this one." And we both saw him, and he was dusky, just gray. And we both caught it so we went in, and he's comatose. And so we got busy.
Oh,
do what?
I said that quickly?
Yeah, it was fast. And so, of course, the team's cardiac team, the arrest team, and immediately they did a lumbar puncture, and it was just like milk. And they shot him full of sulfur, but he was dead in 20 minutes. And it happened that he had I'm going to tell you in a minute. What, pneumocystic, no, not pneumocystic. What is the one, I'll think in a minute, but it's a gram-negative rod. It was, I almost said it, but it was an infection caused by the gram-negative rod, and I thought it might be in here. I'll think of it in a minute. The doctor had gotten a decent history. Here's what happened. The doctor got the history. 3 nights before in Oklahoma City, the bus station in Oklahoma, he had an altercation with somebody, and they hit him in the nose, and it bled a little, not much. So what happened was, he was carrying, I almost said it, he was carrying the germ. He crusted over, healed, and then 3 days, it crusted and healed. But the night at the bus station, or that morning, when he blew his nose or cleared his nose out, it was probably tender and sensitive, and that germ went straight into his bloodstream. And so, it's killing me not to come up with the word, but it got in his bloodstream and killed him. Now, does everybody who has it die? He had DIC. Oh, besides
so
his
DIC killed him?
The DIC killed him. Yeah, that's what killed him. When she and I saw his coloring, and I went in, he had petechiae that had started, and I'm telling you, in front of our eyes, the petechiae joined like a birthmark. They just went together. That's how fast DIC was working.
So he's bleeding
out. Here, and bleeding in there, bleeding out here, or clotting, and it was just such a visual DIC.
Meningitis.
Do what?
Well, like a meningitis?
Yeah. That is what it is. What's the word before that? But it is a meningitis.
Viral.
What?
Viral bacteria. Meningococcal? Or?
I'll think of it in a minute. But it is meningitis, is what it is. And but Now that was the gram negative that caused that. And why it triggered DIC. I mean, it was the germ entered the bloodstream, but it didn't have to throw him into DIC, but it did. And nobody knows why that ever does that. In my camp nursing, several years ago, I think I was 46 and she was 26, the second nurse. And she had just gotten out of graduate school at Vanderbilt with her master's. And she didn't have children, she just did it. And so we're there as the two nurses, and she told me of her incident with DIC. And she said, what happened? She was at graduate school, and so you don't have to die of DIC, but boy, you're lucky if you do live. She said that she's a eating disorder, bulimic. Mm-hmm. And she, it was exam week, and she said she noticed a blister on her heel was streaking up her leg, so she went to student health, and of course they put her on an antibiotic. But being an eating disorder person anyway, she took it 3 days. The streak cleared up. She quit her antibiotic. Finished exams.
Was it a meningococcal?
Meningococcal meningitis. That's it. Meningococcal. Thank you. Meningococcal meningitis. And thank you, Marilyn. So she quit it. She finished exams and started home to East Tennessee, Maryville. And she said she was about 2 hours out of Maryville. She couldn't go anywhere. The fever had started again, and she had to stop at a service station. And she said, I realized I could not drive anymore. So she called her parents, and they came and got her and took her home. She said she got to bed and, settled down for the night. She woke up in the morning and started to get miserable. Got up to get up, and she realized she couldn't walk. She just felt so bad. She crawled to her parents' bed and told them, I'm sick. And they said she was splotchy. Well, I mean, it didn't look like, it hadn't gone together like birthmarks, but it was that splotchy, real splotchy. She was clotting superficially, but nobody said that right out. So they put her in the car, went to a doc in the box. She said it was 8:45 in the morning. They opened at 9. And she said, I owe my life to my stepfather, because I just said, we can lay here. I can lay here for 15 minutes. He said, no, we're going to the emergency room. She must have looked that bad. They took her to the emergency room, and please don't do it. You may feel like it, but of course she got scolded for coming to the emergency room at 9 in the morning. Why she didn't go to her own doctor, and they'll do that. We're vicious, and they got scolded real bad until her blood work came out, and her WBCs were 50,000 or whatever, and they are real nice now, and they send her to an oncology floor. They feel sure she's got leukemia, and then she's splotchy. She looks like she's bruising. So they took her to the hematology or the oncology floor, thinking she had leukemia, and she said the last thing she remembered at that time was a doctor came in and wanted an LP, lumbar puncture, right then. And she said, I remember seeing him hold it up, and it was just as white as milk. And it was the meningococcal meningitis. And that's the last she remembered. But she was at the right place at the right time, and they were able to save her. She said her immune system is terrible. it really took a punch out of her immune system. But she lived, and that was good. So that's DIC, bleeding and clotting. You're kind of bleeding out at the surface and clotting, and you're bleeding, and you're doing the same thing internally, and it's the oddest thing why it starts. And but you're never to have heparin again after it does get started. And I think that's what I want to say. Now, let me, I do want to mention a few tests that I hadn't mentioned. Let's see. Well, of course, bone marrow, to check and see if your bone marrow is okay, they're going to insert a needle into your bone marrow and aspirate bone marrow out. And still the best place is the iliac crest. The iliac crest is still, they can do it from long bone. And a lot of doctors do it from the femur. But they also, that's an easy one to get to, is the iliac crest. And it's not anybody we want. INR, I think we've talked about it. I just remind you it's your clotting one. We've talked about that, 1 to 2, something like that. Prothrombin time, we've already talked about that one. We want prothrombin about 10 seconds. That's on your card. PTT, 20 to 40 seconds. That's on the card. And then, of course, biopsies, CTs, BUN. You know, we're interested in how much junk is left in our bloodstream. I do want to mention sedimentation rate, SED rate. And you don't have a norm on that. I'm not asking you to remember a norm. I don't know a norm. I just know I can tell if an error shows it up or there's an H. And that means inflammatory process is going on. And you and I have a lot of inflammatory going on in our body. It just is happening nowadays with antibodies and out there that we're exposed to. The body fights. And so the SED rate is up, but it indicates injury or inflammation. I wanted to mention SED rate, but I also want to mention CRP. C, reactive protein. It's a pre-run of SED rate. If the CRP is, it lets you know more's coming. They've got some inflammation and injury that is pretty noteworthy. So CRP is kind of a precursor to the SED rate, and anytime you see them high, there's inflammation going on. I've already mentioned D-dimer last week, I think it was. I told you it has to do with clotting, and I told you there's no number for it. Guaiac, G-U-I-A-C, or occult is blood in that area. All right, that is, I think, what I want to say about blood. And let's ease right into well, let me share just before we do, because I think it's good to. Volume expanders, because sometimes we need an expander for our blood pressure and so forth, and water or saline's good, albumin is good to just get our blood pressure up. I'm just going to tell you to Google, if you nursed, private duty, family member, if you need natural diuretics, I think we mentioned them last week, cucumbers and asparagus, but there's also anticoagulants. They're foods that increase our clotting time. If we're inclined to clot early, and you can Google them, but peppermint will do it. Aspirin, of course. Curry, prunes, those will all, but you don't have to learn them. You can always Google foods that increase bleeding time or decrease. Eggs, milk, and all will decrease clotting and bleeding time. All right, now let's slip into shock. And shock is just, it's on the YouTube, one of the YouTubes. I think it's only 30 minutes if you've seen it. The most famous, the most common shock is hypovolemic. Our volume is down. And we've already talked about, I think, that you and I have 10 pints of blood in our body. We've got 5 quarts or 5 liters. Of course, each liter is 2 pints. So we've got 10 pints, and the medical community calls them units, but I wanted you to realize they're 480 to 500. And again, some of this I've already been over, but if we lose 20%, we lose 2 of those pints, or a quart, that's 20%. Your life is in danger. And and you know, blood on the concrete looks like a lot when it isn't a lot, but and I may have told you this, Dottie West, the country music singer, if you recall her scenario, she was late for the Opry and hitchhiked. And the fella, I guess he was so excited to have her in the car, at the Cloverleaf he wrecked, and she was badly injured and was touch and go for a long time at Vanderbilt, and then she did die. The wreck lacerated her liver, and so the newspaper would say, Dottie has been transfused with 3 times her body volume. Well, I said to myself, well, that's 30. If it's 3 times, that's 30 units she got. If it's 3 times her body volume. And sure enough, the last article said she got 33 units of blood while she was in, because that liver was just pouring it out. So that's good to know. Now, hypovolemic, the most famous, and that's loss of blood. And also, the gram negative, if you are septic, your bloodstream is full of bacteria, so your volume of good blood is low, so that's kind of hypovolemic because you don't have the right blood supply to meet the demand. There's cardiogenic shock, so we got hypovolemic, we got cardiogenic, and you think about it, cardiogenic, the pump just isn't able to push fluid enough through everything. And so really your symptoms are a lot like hypovolemic because the blood's just staying out in the tissue and not into the vital organs. So you're hypovolemic for all practical purposes, but it's the heart that's the culprit. And then the third shock is they go on, it changes its name off and on, but it's now called, well, distributive shock or vasogenic shock. Distributive or vasogenic. And I think also it's called circulatory shock. So distributive, vasogenic, circulatory. And now if that isn't confusing enough, so we've got 3 kinds of shock: hypovolemic, cardiac, and vasogenic. But under vasogenic or circulatory are 3 others. And those 3 under vasogenic are septic. Well, you know what septic, you're just loaded with bacteria. Anaphylactic, and then neurogenic. If you'll think of Christopher Reeve, he had neurogenic when he had his injury to his spinal cord. So that tells you right off it's neuro, and you go into shock. Now, the symptoms of all 3 are similar. Well, not the last one. Vasogenic, distributive, circulatory. Those symptoms are different than hypovolemic and cardiac. And I told you those 2 are similar, hypovolemic, cardiac, because in essence your organs aren't getting the nutrients and oxygen, and that's one's because the volume isn't enough, another is because the blood's staying out in the tissue because the pump can't bring it back. Well, you know what you do for cardiac. You try to give them a cardiogenic drug and get the fluid down. So diuretic and a cardiogenic drug, and get that pump to do better and less fluid to do it. Now, so that's we'll try to treat cardiac that way. Hypovolemic, we need to just give them fluids and blood. That's easy enough. Now, here's what happens. And you say, all the symptoms. I want you to think of an inner tube, and it gets a puncture. Well, we can't let it go down. So it's losing pressure, so blood pressure is going to go down. But I can't let it. So I've got to get a pump going on it. So heart rate goes up to try to keep it up. And in doing that, when the blood pressure is inclined to go down, we have those baroreceptors that sense blood pressure at the base of our brain, baroreceptors. When it has that inclination that the blood pressure is trying to go down, it makes us breathe faster. So we'll take in more. So you're tachypnic. So you're breathing faster, your blood pressure's going down, your heart rate's going up. And I just think this one's fascinating. As soon as that blood pressure is trying to go down and we're trying to keep it up, it stimulates the sympathetic nervous system. And you know what the sympathetic nervous system does, fight or flight. It squeezes down on our vessels to push blood to our vital organs. I just think that's the most wonderful thing, trying to keep our body, the vital organs, full of blood. So, this is what's so interesting. When it clamps down, anything on the surface comes up, which is wet, and pushes blood down into the stream so it'll hit the heart and kidneys and so forth, so you're moist. So anybody that's in shock is clammy. And it's simply because the clamping down pushed surface hydration up, and you're clammy. Now, when it clamped down, some red cells clamped and broke. And so now I've got broken red cells with fragments in the bloodstream. So you guessed it, when it hits the nephrons, it's going to clog them. And my urine's going to be red, because the filter now has fragmented red cells, and the urine is going, we hope, through, and your urine's red, hematuria. We hope to get this rectified before it keeps pushing down and breaking more red cells, and then it's going to cover the nephrons, and I'm going to have renal shutdown because nothing can get through. So that's why shock shouldn't go on too long. There's the danger of renal shutdown if I clog the nephrons. The Creator realized we didn't need to be digesting food, so the GI system really slows down. The liver slows detoxing, and then and I was going to see the interesting thing, because of the shunning of the fluid, your brain stays, well, the good Lord knows your neurons need, they've got to have oxygen or they die. And sugar and oxygen it needs. So if you've ever been with a shock patient, they're as clear as a bell when you're talking to them. And they actually remember real well too. It's because it's just so last to go. Consciousness. Let's see. Pupils, if you're in shock, they open at first to get as much oxygen in as they can, and then they become pinpoint. Isn't that right? Toward the end, trying to hold in what they got. They go into, tachypnea was trying to blow off the waste and bring in oxygen. It's best because if you're losing blood on the concrete, you don't have as much, and we need to pack what you've got with as much oxygen. So that's thus the tachypnea. But your inclination is that you're going to be acidotic and respiratory acidosis. Urinary, you will be probably oliguric, small amount of urine, especially if you're losing blood, that system, the circular system. So they need an IV fast to keep that, but they really need blood if they're losing blood for the red cells. Now, the stages, the body's so great, compensation, and I've just told you how it compensates by breathing fast. And they call the stages, the first stage compensatory. It's compensating. That makes sense. The body's trying to compensate for each other. The second stage is called progressive. We're not able to, we're losing some ground. You're not gaining ground, but you're not losing a lot. It's progressing though. Then the last stage is refractory, which usually is irreversible. Anytime you hear the word refractory, you know it's not good news. It usually means something's irreversible. And on our symptoms, where we said heart rate increases, breathing tachypnic, you increase your breathing, you are clammy, you're pallor. And then that you're pallor, you're pale, because of vasoconstriction, it pushed the blood down to get to the vital organs and left you pallor and clammy. So just all the symptoms of shock. And it does you so well to keep those in mind. I've already told you, cardiogenics very similar. Now, let me go to distributive or circulatory. And septic, I don't need to say much. You know what septic shock is. It's bacteria too much in the system and in the vascular system to the point it's crowded out red cells and white cells that need to clot, red cells that need to be carrying oxygen and repairing protein that repairs cells. So it's a bad shape if you're septic. And we know what we do for it. Antibiotics, IVs, and hope it works. Now that's one of the three under circulatory or distributive or vasogenic. Now the look of vasogenic, I want to bring that up first, the look in those three. It's shock, but you're not pallor. That's the reason I give you the name vasogenic, because you know, I'm going to stop to say, I've already mentioned, when you blow up a sphygmomanometer and you let it off, and your first sound is blood hitting the side of the vein. First sound. And then you hear it, and then it quits when it's filled back up. And those are your systolic and diastolic. And you know, with our hypovolemic shock or cardiac, that pulse pressure, they call it, it's a width. 120/80 is ideal, about 40. If it's any less than that, think about it. You have less blood, because if you pumped it up and the first sound is, we'll say 90 or 70, and the next sound's just 20 down, you didn't have much to fill. So for hypovolemic, you're going to have a small pulse pressure because the first sound, and then it fills it up quickly. With circulatory, vasogenic, distributive, that three, the three under there, septic, neurogenic, and anaphylaxis, you've got too much and you're flush. So, listen, I heard the noise, but it's a long time before I hear the last, so the pulse pressure is greater than 40. And they are flush looking. Anybody's got septic shock, you can believe they're flushed. Neurogenic, that's an injury to the nerve. It may be anesthesia did it, not permanent, but you may be in neurogenic with anesthesia. Overdoses can cause that, the neurogenic shock. Of course, anaphylactic, that's that freak again, freak, where all of a sudden you are a camper from way back, touching poison ivy all your life, and then when you're 28 years old, you get poison ivy and it goes into anaphylaxis. Why the body all of a sudden says, my goodness, this looks like it's going to kill me, and I think I'm going to pour out histamines and try to get rid of, and of course then that surge of histamines can be dangerous and flip us into anaphylaxis. And nobody, who knows why? I think it's just another odd thing. I was in nursing school with a woman, she's still alive, she wears a bracelet, an alert bracelet, but she was in my class, and she came to clinical with slits for her eyes, her face this big. What in the world? And she said, I don't know, doctor doesn't know, I'm just swollen. And we knew it was systemic because, it's all in her whole body. And so she said, I don't hurt and nothing's wrong, but we don't know what it is. So you can't say it's the soap she's using because it's not just topical, it's internal. So she did clinical. She felt bad. She looked funny, but she she did clinical. Next day she was better, and we said, what happened? She said, well, I went back to the doctor after clinical, and the doctor quizzed me and said, you've got to think, have you pricked yourself? She remembered she was drawing up penicillin and pricked herself. That did that number on her. She'd taken penicillin all her life, but that prick of the needle was just enough to throw her into anaphylaxis. As I said, she wears a bracelet now and doesn't receive penicillin. So why it happens, nobody knows why. You've never been allergic to anything, and all of a sudden you are. It's to be taken seriously. And we'll get into it on hematology, but immunology, where you're allergic or not allergic, and why your body all of a sudden decides something's foreign or not and starts to fight. And of course, autoimmune system is that. The autoimmune whole concept is the body thinks something doesn't belong to it, it starts fighting, and that inflammation pours out. Questions on blood shock? I think. So what do we do for distributive circulatory? You keep them alive. That's all you can do. What did we do for Christopher Reeve? Just kept him alive on a ventilator until he did die. But there's nothing we can do. They said his spinal column was just injured. It wasn't severed. What do we do? We keep him alive. What do we do for sepsis? We've talked about it. What do we do for anaphylaxis? Well, you know what you do is epinephrine and EpiPen. And for adults, and of course they come ready-made, and usually if you work at a facility, they've got them stocked for you. It would benefit you to orient yourself to it so that if you had to work, you don't have to read directions while they're in anaphylaxis. But mostly it's just take it apart and jab them, and it's 0.5 for an adult, 0.3 of the epinephrine for children. And we get the warning. We get the warning by my friend had a reaction, and she didn't go into an anaphylaxis. But sometimes you don't have the warning, and that's where it's fatal when that happens. Anything else? I think this will conclude session 5.